Thank you, Vijay. Good morning, everybody. I would like to welcome all the delegates to our HIP webinar. This webinar is part of a series of webinars organized by BIOS UK. It's mainly aimed at the senior registrar or junior consultant level, and they cover core topics. Today, we have lined up 4 talks, very knowledgeable and experienced speakers. I'm sure everyone would benefit from their knowledge. And I would like to thank BIOS for giving us this opportunity. We have 4 talks lined up as it's been there on the screen. First one, we will cover FAI. Mr. Ravi Gudena will cover that. Then we have consenting for total hip replacements. What are the principles and pitfalls by Nikhil Shah. Then we'll have a total hip replacement for secondary osteoarthritis of the hips, special scenarios, Mr. Kuntal Patel. And we will cover the periprosthetic fractures, Mr. Nikhil Pradhan. So without wasting much time, I would like to invite the first speaker, which is Mr. Ravi Gudena. He is a consultant in St. Helens and Western Hospital. He has special interest in managing young adult hip surgery. He has extensively worked on them. He has done a fellowship on them in Canada. And I'm sure we will benefit from his knowledge. Ravi, all yours, please.
Good morning, everyone. Can everyone hear me?
Yeah, we can see and hear you, Ravi.
Okay. Welcome to the BIOS webinar. I'm just going to go through the femorostabilar impingement. During this talk, I will just go briefly through the hip impingement definition and etiology, and the symptoms the patients present with, and the investigations we can do to diagnose this problem, and the treatment options briefly. And I'll just briefly go through the evidence out there regarding the outcomes and different management options. The femorostabilar impingement, if you look at the definition, it is basically the mismatch between the femoral head shape and acetabulum, which causes the excessive friction leading to the labral tears and chondral delamination. And this in turn gives you the groin pain. The groin pain is mostly on the superolateral aspect of the acetabulum rather than the inner or medial groin pain. And the damage to the labral tear and chondral delamination causes early arthritis. If you look at the studies, etiology, there are a lot of etiological studies looking at the cause and when this femorostabilar impingement starts. Basically, it is the repetitive injury of the proximal femoral physis during the younger age group. That's because of the impact sports, what they do during the development age. The repetitive injury to the physis causes the CAM impingement. It's been proved by different studies, and for a couple of studies I have noted here. But the Mark Philippon and Nepal and Saban Rock, they looked at specific sports activities, including ice hockey, football, and basketball. And they have noted that there is increased prevalence of these CAM impingement development if these players are doing during their developmental age. If you look at the hip impingement, there are different types of hip impingement. One is the CAM, which I briefly mentioned, which is on the femoral side. And the second one is the pincer, which is on the acetabular overgrowth. And the third one is the mixed, combined CAM and mixed. As I mentioned in the previous slide, there are a lot of etiological studies saying that how the CAM impingement is developed, but there is no specific reason why the pincer type of hip impingement develops. There are no studies showing it. However, if you have a coxa profunda hip or a protrusio hip, obviously that causes the pincer type of hip impingement. If you look at the CAM impingement, it is on the femoral side, the head-neck junction abnormality, which causes the reduced head-neck offset. This causes increased shear forces on the acetabular rim, causing damage to the labrum and articular cartilage. If you look at the X-ray, the typical description on the X-ray is like a pistol gun deformity. The acetabular side of the impingement is called pincer. This is because of the linear contact between the acetabular rim and femoral head neck junction causes the labrum to be ossified. And this results in the deepening of the socket and decreases the range of movement. This in turn causes the damage to the acetabular cartilage, especially along the rim of the acetabulum, chondrolateral junctions. But if most of the times we see the mixed type of impingement, which is in 80% of the cases, it's both cam and pincer. If you look at the presentation of the symptoms, usually the pain is the main symptom because the labrum is a pain generator. It is highly innervated with the nerves, and I will show you a study where later on where we looked into the innervation of the labrum, which shows anterosuperior and posterior part of the labrum is highly densely impacted, innervated with the nerves. So that is the reason if you have a tear in the labrum in these areas, you get pain. Along with pain, you have associated mechanical symptoms. It could be clicking or it could be giving way, or sometimes patients will say the hip gets locked in certain positions where they need to move the hip around to unlock it. But be sure that the pain in this type of labral tears, as you can see in the picture, it's on the anterosuperior part of the labrum rather than the inner part of the labrum. Diagnosing by examination is quite straightforward, which is the anterior impingement test. We all do this regularly, even with arthritis patients. It's a flexion, adduction, and internal rotation. In arthritic patients, you have this movement is limited, but in hip impingement patients, you have this movement, flexion, adduction, internal rotation, but the movement is more painful, and it can be reproduced with a click. The second test is the Faber test or Patrick's test, where you can see in the second picture, you basically measure the distance between the couch and the knee on the good side and the affected side. And it is quite sensitive and specific test for intra-articular pathology. There are other type of hip impingement tests which we do, which include posterior impingement test. As you can, it's actually Prof. Ganj demonstrating this in the picture, where you bring the patient to the edge of the end of the couch and extend and externally rotate the leg. That shows the posterior impingement test. And there is a iliopsoas snapping and ischiofemoral impingement, which can be demonstrated. But another important thing which we more and more commonly coming into light is subspinous impingement, the impingement secondary to the anterior inferior iliac spine. If we're doing arthroscopically, we can see this clearly causing impingement in deep flexion and internal rotation of the hip. Investigations wise, a well-centered epipelvis and a lateral hip X-ray are very important. When you say well-centered pelvic X-ray, the pubic symphysis should be in line with the coccyx within 1 to 3 centimeters and equally demonstrated obturator foramen equal shapes. And this is the pelvis. You can comment on the retroversion of the acetabulum by seeing the ischial spine, and you can comment on the cam and pincer lesions. On the lateral X-ray, again, that's where you comment on the cam type of impingement. You can measure the alpha angle, which is very important, and it's been quite commonly asked in the FRCS exam as well. It is more than 55 of alpha angle, which is the head neck junction. If you can see in the pictures where there is a loss of offset or head neck junction transition is missed, the alpha angle is more than 55 degrees. Again, you look at the head neck offset. If the head neck offset is less than 9 millimeters, it is abnormal. That suggests it's a cam impingement. The further investigation choice is MR arthrogram. MR arthrogram is quite superior to the MRI scan. MR arthrogram on the MR arthrogram, we can easily diagnose the labral tears and chondrolabral separation. But unfortunately, it's not very good to detect the chondral delamination. For chondral delamination, the more specific test is the delayed gadolinium enhanced MRI scan, DGEMRIC scan. Not many of the UK centers still have this scan facility, but as you can see in the third picture, the chondral delamination is clearly shown on the DGEMRIC MRI scan compared to the first picture, which is the conventional MRI scan or MR arthrogram. Because this is an important prognostic factor on how the outcome depends on the chondral delamination. So it's very important to diagnose it. Regarding the MR arthrogram, the validity, we have done a study at St. Helens Hospital, which has been published as well. We looked at it about 132 patients who had hip arthroscopy, and we looked at the labral tears, and the MR arthrogram is relatively accurate compared to intraoperative findings in diagnosing the labral tears and the position of the labral tears. But if you look at the cartilage delamination, it's not very sensitive in diagnosing the cartilage delamination. MR arthrogram suggested there is no cartilage delamination, but intraoperatively we noted that 78 patients had cartilage delamination. It is very important as it dictates the outcome on the patients. So the sensitivity is not great, but specificity is around 76 from this study. Again, looking at the labral tears from this study, with both sensitivity and specificity is around 84%, and it correlates with the rest of the studies which been published. So once we investigate and find the diagnosis, the management can be conservative and operative management. The conservative management, mainly activity modification and physiotherapy, doing the gluteal strengthening exercises, and then we can consider injections, which can help for both diagnostic and therapeutic purposes. The operative management is obviously either you can consider an open procedure or hip arthroscopy procedure. There are a couple of studies which you need to know, especially for FRCS Orth exam, is FASHION trial, which is one of the largest hip arthroscopy randomized controlled trial, which was done by the Griffin et al. And there's another one, FATE study, which was published in February last year in BMJ, which was done by the, again, multi-center study, but initiated by the Oxford group. Both these studies looked into the arthroscopic, hip arthroscopy and conservative management in the hip impingement and labral tear patients. At 12 months, the hip arthroscopy group did better with international hip outcome scores, and they achieved much higher scores and satisfaction rates. The surgical treatment, as I mentioned, it could be an open surgical hip dislocation or hip arthroscopy. Open surgical hip dislocation is demonstrated by the Ganj. First of all, as you can see, the head neck bump in the left-hand side picture compared to the right side where the osteochondroplasty performed. It looks more satisfactory procedure because it's more hands-on and you can have the complete visibility of this one. But it is quite traumatic because you do the trochanteric flip osteotomy, and also you will put the blood supply to the femoral head in a bit more compromised position. And this is the Stabilar rim trim, like a pincer excision and a labral repair, which is mostly done the anterosuperior part of the labrum. This is one of the largest systematic review looking at the outcomes and complication rates with the open surgical dislocation versus arthroscopic and mini open procedures for hip impingement patients. And the conclusion is, with a hip arthroscopy, you have better outcomes and less complication rates compared to the open or mini open. In the open procedures, one of the main complications is the trochanteric non-union. If you go for the hip arthroscopy, the indications are mainly the cam and pincer type of hip impingements and labral tears and loose bodies and any chondral damage. We can deal with these through the hip arthroscopy procedure. The contraindications are very important. Where you have arthritis of less than 2 millimeter joint space, then you should try to avoid the arthroscopic procedure, and the other contraindications are listed here. The hip arthroscopy, the labral repair and cam resection, you can see it in the pictures. As I suggested before, the acetabular labrum is the pain generator, and this is another study we have performed looking at the innervation of the labrum and the density of the nerves. And we have noted that the anterosuperior and posterosuperior part of the labrum is highly innervated and causes the pain generator. That is why either a debridement of the labrum or repairing the labrum is very important. And also when you are repairing the labrum, you need to be aware of the blood supply. There is no intrinsic blood supply to the labrum, but the capsular side is more vascular zone compared to the inner side, which is the articular side of the labrum. There is another study which is very important regarding the labral repair versus labral debridement. And it's been noted labral repair has better outcomes in long term compared to the labral debridement. This is the commonly quoted study, which is Mark Philippons regarding the outcome of the hip arthroscopy. They looked at the patients with a 10 years outcome, and they have noted 34% of the conversion rate to total hip replacements in 10 years who were undergone the hip arthroscopy. When you look at that number, it looks quite dramatic, but if you look into subcategory of those, this is his initial series of the patients, and a lot of patients has a joint space of less than 2 millimeters. That means established arthritis. And those are the patients who had 68% conversion to a total hip replacement within 10 years of the hip arthroscopy procedure. However, if the joint space is well preserved, especially in the non-arthritic patients, the conversion rate is only 2%. Another important factor is the age factor, where above 40 years, the conversion rate is higher into total hip replacement. Again, they looked in particular with the labral debridement and the labral repair, and they noted the labral repair has higher patient satisfaction. So in summary, the hip arthroscopy is a very good procedure, and with a less number of complications and better outcomes, but it is a steep learning curve, and you need to make an accurate diagnosis what we are dealing with, the hip impingement and the labral tears. And you need to be aware of the extra articular causes and don't be caught out with these. And sometimes you see the intrasubstance tear with a positive bubble sign on the intraoperatively, but that suggests that there is a proper labral tear and you need to repair that as well. So in summary, the hip impingement is a well-recognized problem in young adults. It's becoming more popular in our regular practice and in the FRCS exams as well. So you need to make an early and accurate diagnosis which can be treated efficiently. This will avoid the early arthritis. Operative management has a better outcomes in long term, and arthroscopic approach is better and with less complication rates compared to an open approach. And be aware of the contraindications. Thank you.
Good. Thank you, Ravi. That was a nice, informative talk. For the delegates, we will take the questions. If you can type them in the chat box, then we can try and reply your questions, or we will take the questions at the end of all the talks. So without wasting much time, I'll like to invite the next speaker, which is Mr. Nikhil Shah. He's going to talk to us about consenting in total hip replacements, the principles and pitfalls. I think most of us know Nikhil Shah. He is a consultant in Brightington Hospital. He has a special interest in mainly hip, pelvis, trauma and complex scenarios. He is our kind of referral person. If you have any trouble, we kind of get to him. I'm sure we will benefit from his wisdom on consenting and what are the principles to follow. Nikhil, after you.
Thank you, Prakash. Can you see the screen?
Yeah, I can see the screen. Yeah, I can see the screen and hear it.
Good morning, everyone. Thank you, Prakash, for a very generous introduction. I don't think I deserve all that. So the purpose of this talk is to look at the principles of consenting within the Montgomery judgment and then apply these principles to your practice when you consent someone for a total hip replacement. This is quite important for all of us because litigation in relation to consent is on the rise. So we need to understand the basic principles. So what I've done in this talk is, in the beginning, we will cover what exactly was the Montgomery judgment. Some of you may already know it, some of you may not be very familiar to it. And then we will try and apply these principles to a total hip replacement. So until the Montgomery judgment came, the Bolam principle was the guiding principle to decide if someone was negligent. And a doctor would not be guilty of negligence if he has acted in accordance with a practice that is accepted as proper by a reasonable body of medical men who are skilled in that art. This means that if you do something that a reasonable body of doctors also do and they think that it is correct, then you are not negligent. So effectively, a peer or another doctor would decide the basis of your practice. The Bolaito judgment was, naturally, when we look at treatments for a particular condition, there can be different views. Some people would always put a nail for a fracture, some people would always put a plate. So what the Bolaito judgment was, that a practice that could be logical and defensible would be considered as proper. So if the judge was to choose between two different viewpoints, this is negligent, this is not negligent, you have to defend your viewpoint by giving appropriate evidence and by using logic. So what exactly happened in Montgomery in 2013? So Nadine Montgomery was a diabetic patient. And for those of you who know a little bit of obstetrics or who remember some principles, these patients have got a much higher risk of shoulder dystocia during vaginal delivery. So basically, the labor is obstructed. It was a practice of this obstetrician not to routinely advise patients of this risk because the likelihood of a very significant complication was quite small, a 0.1% chance of hypoxia and a 0.2% chance of brachial plexus injury. And the doctor felt that if this risk was explained to all patients, they would all choose a cesarean section, and that was not necessarily in the best interests of the mother. So this option was not discussed, and at planned induction at 39 weeks, unfortunately the worst happened during vaginal delivery. The umbilical cord was obstructed and the baby had very severe disabilities because of a hypoxic brain injury. So the mother naturally claimed that if she had been warned of this risk of shoulder dystocia and the catastrophic consequences, she would have gone for a cesarean section. In the lower courts, they applied the Bolam test and something called the Sidaway judgment. So the Bolam test you already know. A reasonable body of medical opinion actually supported this obstetrician's practice. The Sidaway judgment was, for a risk to be significant, it must carry a grave risk of substantial complications. So the original case was actually dismissed by the court that the doctor was not negligent, but the claimant appealed and it went to the Supreme Court. What happened in the Supreme Court? They looked at the entire case and then decided that patients themselves have rights. They have the right to understand what the treatment involves, the right to understand the risks and benefits, and the right to choose their treatment. Treatment is not something that is just given by the medical profession and passively accepted by the patient. So the Supreme Court accepted that if the patient had been appropriately warned, she would have not undergone the labor and she was therefore entitled to damages. Now, this was a landmark judgment because it changed the way we look at consent. What the judgment said is that the patient should be made aware of any material risks which are involved in the recommended treatment and of reasonable treatment alternatives. And what does material mean? It means something to which a reasonable person would attach significance. So for one person, something material may be the risk of a sciatic nerve injury from a hip replacement. For someone else, he might think that heterotopic ossification is more material. For yet a third person, it might be the risk of catching COVID if he goes to the hospital. And not only that, but the doctor should be aware that a particular patient would attach significance to that particular risk. And this is the hard thing. How can we know what a patient might find materially relevant? So the emphasis shifted from the doctor to the patient, and consent will now be assessed by the courts, not based on what a reasonable body of medical opinion will think about your consenting, but what a reasonable patient will want to know. And the patient will have the right to choose the treatment option rather than the doctor. Not only that, but no longer will a peer decide on the reasonableness of consent. It will be the court that will decide what is reasonable and not the profession. A doctor's duty is not fulfilled merely by giving percentages to the patient or basically bombarding him with so much information that they simply do not understand, nor by demanding the signature on your consent form. So this is not really what the court would say is informed consent. So what is informed consent then? It starts with your clinic appointment and a dialogue between the patient and the doctor, an explanation of all the reasonable treatment alternatives, including conservative treatment or the risk of doing nothing, and a clear risk and benefit analysis of each of the proposed treatment options. The patient should understand these options properly. So what changed with Montgomery? To be honest, nothing changed. If we look back at what the GMC and the Department of Health told us in 2008 and 9, all these principles were already there. But what the judgment did is it converted these principles into law. It has basically spelled out what we should have been practicing anyway. So for the vast majority of you who were following GMC guidelines, your practices will not really change much. So what does the GMC tell us? What is the doctor's duty? We should focus on the patient and the risks which are specific to them. Find out what concerns them, find out their individual views, inform them of any serious and adverse outcomes, even if the risk is small. So the risk of mortality perhaps is small after a routine total hip replacement, but when it materializes, it's a very grave consequence. And you must tell them of less serious complications if they are more frequent. Not just that, the risks have to be individualized, and we'll come to that in a minute. The Department of Health had also outlined these principles. The option of doing nothing. Do we always discuss conservative treatment with our patients who come with pain? Do we always discuss that there can be alternative treatment and that may include doing nothing and basically just suffering from the pain? Some of us may do that, some of us may not. What are the risks if you do nothing? We should provide a balanced information about the benefits and the risks. Often you will see, and if you reflect upon our consenting processes, if we think we are going to go towards surgery, perhaps we might underplay the risks. If you want to go towards conservative treatment, perhaps you might overplay the risks. What we need to try and do is give a balanced risk, and then we have to find out if the patient really understood it. It's also important to make an appropriate record in the documentation. So let's try and apply these basic principles to consenting for a hip replacement. So look at these x-rays. The x-ray on the left is a very slightly dysplastic hip in a patient who has a lot of pain and no arthritis at all. The x-ray in the middle has a little bit of arthritis, but not really bone on bone. And the third x-ray has got significant bone on bone arthritis. Would you do a total hip replacement for all of these? So what is important is patient selection. And we know from evidence that if you do hip replacements for premature arthritis, which is not bone on bone, the subjective outcomes are very poor. Some of the commonest problems that we see in our Friday morning MDT of patients that are referred into our hospital with painful total hips. And if you look at the original x-rays, you begin to wonder, why was the operation done at all? Where is the grade 4 arthritis? So make sure you select your patients properly in terms of pain, end stage grade 4 arthritis, compromised function. Once you have done that, we have to appreciate that the conversation begins by managing their expectations. Even with a hip replacement, you will be surprised to know that 7 to 15% of patients may be quite dissatisfied because of pain or leg length inequality, because they are persistently limping, or because of a big complication. It's important to appreciate their comorbidities. And this is where the risk stratification comes in. So part of Montgomery is that the risks should be individualized to the patient. What does that mean? A person who is obese and who has diabetes will have a much higher risk of infection than someone who has normal BMI and does not have diabetes. A person who has stroke or Parkinson's disease will have a higher risk of dislocations. Someone who's had previous hip surgery or previous sepsis or multiple steroid injections may have an increased risk of infection. And these are the factors that you need to find out in your clinic when you take a thorough history and individualize the risks to that patient. If there are any modifiable risk factors, it's important we correct them so as to improve our outcomes. Because that's what Montgomery told us. Focus on the individual patient and the risks that are specific to them. So coming back to our treatment options. What are the treatment options for arthritis of the hip joint? Will everyone be offered a hip replacement, or is conservative treatment a very valid option? So that is the option of doing nothing. And what I tend to do with my patients is discuss the ladder of treatment, starting from the simplest thing, the option of doing nothing, conservative treatment, which includes weight loss, injecting the hip joint. Some of us may not believe in the concept that hip arthroscopy is indicated at all if you see any arthritis on the x-ray, but there may be another viewpoint where they would offer a hip arthroscopy even in arthritic hips. And whatever your philosophy is that you can justify, that's part of your treatment ladder. And then finally, we go to surgery. Once you have discussed the options, it's very important to discuss the prosthetic options. What type of a hip are you going to do? And is that option backed by sound evidence? Are you going to do a fully cemented or a hybrid or an uncemented, or what bearing are you going to use? Believe me, each of these slides that I have put in, I have dealt with as a negligence claim. So none of this is a figment of my imagination, but over all these points, there are doctors in the UK who have been sued. And then we come to discussing the risks, starting with the worst case scenario first, perhaps, a risk of mortality from a variety of different problems, a risk of thromboembolic complications. Then the usual risks of infection, dislocation, leg length problems, damage to the nerves, some of the rarer risks like abductor tendon injury perhaps, or grade 4 heterotopic ossification, and then the long-term risks. You also have to try and explain to them the worst case scenario, that if the hip does get infected and you cannot solve it with a DARE procedure, and you do a 1-stage or a 2-stage revision, and it remains infected, and you repeat your revision and it remains infected, what's the worst thing that could happen to them? They might end up with a girdle stone excision. Rarely, they might actually lose the limb. I hope that none of you have ever been involved in disarticulation of the hip joint for deep infection. It's a very unpleasant experience. Very rare, but when it does happen, it's a complete devastation for that patient. And then in the modern scenario, the risks of having surgery in a COVID-19 environment. You have to try and stratify these risks to your individual patient. Someone whose ejection fraction is only 30 and you're going to do a hip replacement on him, his mortality risk will be much higher than someone who is fit for surgery. And now this is one thing that we tend not to pay so much attention to. We explain the risks to the patient, but many times we don't actually explain the consequences of the risks. And I have done several cases in the clinical negligence scenario where a patient has admitted, yes, I was explained that there is a risk of injury to the sciatic nerve, but I don't know what it means. I don't know what is neuropathic pain. I did not know what a foot drop is. Doctor never told me that I would not be able to climb a ladder or I would lose my job. So it's important that you actually explain the consequences of those risks to the patient. What exactly happens if you end up with a girdle stone? What exactly happens if you have to have a hip disarticulation? Or if it's a knee replacement and above the knee amputation? Make sure that your patient then understands these risks. And this is again a very important part of informed consent, the collection of positive feedback that the patient has understood the risks and has therefore made an attempt to understand the choices and has selected actively the operation. And this is sometimes something that a lot of us may not have in our consent processes. So this is a simple dissemination of information. You have a discussion in the clinic, you copy a letter to the patient. Most hospitals have joint replacement classes and information booklets. The information can be given in electronic or digital formats. Many consultants have their own private websites. Hospitals have their own private websites. And then once you have done that, you have to determine, does the patient understand the options? Does he understand the risks? Have you given him enough time to think? And have you answered all his questions? Increasingly, it is difficult to be able to list a patient in the first clinic itself without actually giving them time to think. It has been tested in court, and unfortunately, the courts have found that the doctor did not give the patient enough time to think and listed him in the first go. The patient thought that that is the only option available, and unfortunately, the doctor lost the case. Then you make sure that you document this process appropriately. Okay, this is very, very important. If it wasn't documented, it wasn't done. The importance of documentation is because the patient can then read your letter and reflect upon it. You can then defend yourself if you were challenged that you have not taken a proper consent. And most important, you have to be able to capture the evidence of the whole process of consenting rather than the end point, which is just the yellow form on which the patient signs. So this is the GMC 4-step model of obtaining informed consent. And we have already covered all of these points before. Make an assessment of the patient's views, his characteristics, his knowledge, his attitudes towards risk. Then decide based on your expertise and judgment, what investigations or treatment are likely to benefit him. And out of these, which options are better, which options are not very good. Explain all of these options to the patient and give a balanced assessment of the risks and benefits of each of these treatment options, including the option of doing nothing. Then give the patient a chance to think about this and let him come back to you and tell you that he's understood everything and this is the option that he wants. Some may say, I don't want surgery. Some may say, give me a hip replacement. You can't really give excuses anymore. It was too busy in the clinic. There are 17 risks. I can't really talk to my patients about all these 17 cases. I've mentioned the main important things. My trust does not allow me to have a separate consent clinic. It spoils my new to follow-up ratio. I did explain to the patient because I always do. That's my routine practice. But I didn't bother because I only do 3-line letters instead of a 1-page letter. I didn't tell the patient everything because I didn't want to make the elderly lady too anxious. And then finally, with the patient to sign the form, and I've written everything on the form. So that means I've obtained consent. None of these excuses will stand in court. So these are 12 commandments of consenting that I hope that I've borrowed from the famous movie. The first is that consenting is a process. Leave adequate time for the patient to understand what you're telling them and to reflect upon the consent. Document the advice correctly. Discuss the option of conservative treatment in every case where it is relevant and record it. Don't overestimate the success, especially if it's independent sector practice. And I've seen several examples of negligence cases where the success rate was vastly overestimated and the complication risk was vastly underestimated. Advise the patient of all material risks that he may find important or relevant to himself or herself. Provide information that is specific to that patient. Risk stratification. Understand the attitudes towards risks and ask them, what do you feel? What would you do if this happens to you? How would you cope if you get an infection in your hip replacement? Don't rush into performing surgery, especially if it is elective surgery. If your patient is in doubt, it is better to give them a chance to think and then follow it up with a phone call or another letter or a second appointment if they still have questions. There is no longer an excuse that you can't organize follow-up appointments or you're too busy. Give the patients the chance to reflect and the chance to change their mind. Don't force surgery upon them. Give them a chance to ask more questions. Avoid consenting on the day of surgery. Okay, and I recently did a case where the process was followed and the consent was taken on the day of surgery. And I actually thought that the case was defensible, but the trust actually accepted liability. Keep good records and then use your clinic letters to demonstrate that you have given appropriate advice to the patient and that consenting is a process and not a point in time. So to summarize, consent is important and now it is a legal requirement. We can borrow the principles of Montgomery to consent for a hip replacement. And I'm sure that you can borrow these principles to whatever your practices are, upper limb, lower limb, knee replacement, hip arthroscopy. Consent is a shared decision making. It's not your choice anymore. It's the patient's choice. The risks have to be individualized to the patient and focus on the pathway and capture the evidence that you have a pathway, not just the signature on the form. Thank you.
Thank you, Nikhil. There was a lot of insight into consenting. I'm sure it would apply to all of us in our day-to-day practice across the specialties. Thank you very much. I think there are a lot of questions on this talk. We'll probably take it at the end. Now we'll move on to the next talk, which is by Mr. Kuntal Patel. He's going to talk to us about hip replacements in secondary osteoarthritis or special circumstances. Kuntal, he's a good friend of mine. He works in Lancashire teaching university hospital. He specializes mainly in hip surgeries. His practice is mainly revision work, and I'm sure his knowledge would be very well received. Kuntal, it's for you to share your screen, please.
Thank you, Prakash. Can you see the screen all right?
Yeah, we can see the screen and hear you. Thank you.
Okay, excellent. Okay. Morning, everyone. I'm going to go through total hip replacement for secondary arthritis, essentially complex primary hip replacement. Okay. So essentially, I'll start off with door classification for the femur. I feel it's very important for selecting your processes and how you do the steps for doing the stem. And then I'll go on to some individual cases like Paget's, DDH, previous proximal femur deformities, post-traumatic cases, especially failed fixations. You'll see quite a few in your practice, and you actually get some clinical cases in FRCS Orth as well. So I think you'll find this quite useful. And then I'll touch on things like essentially takedown of hip arthrodesis, but that's thankfully not very common. Okay, so let's go on door classification. So I would certainly urge all trainees to look into this when you are doing your pre-op planning for hip replacement surgery. So a lot of the cases would be door B. That's probably the commonest in my experience and based on the evidence. But certainly beware of door A femur and door C femur. Now, if you don't spot this, the difficulty is if it's a door A femur, what you are likely to get is a diaphyseal fit, and you could undersize the stem, and thereby these are the patients who will get thigh pain. So the trick here is to make sure, A, you've identified it, and secondly, you address it. And the way to address that would be to ream the femur actually, and then broach it. Depending on whether you're using uncemented stem or cemented stem, that's probably your discretion, but you make sure that there is a diaphyseal metaphyseal fit and not just a diaphyseal fit. And equally indoor C femur, this is where the cortices are really thin, and I certainly would urge you to consider using a cemented prosthesis as compared to a very large oversized uncemented prosthesis. Whereas with door B, you should have both options available. Okay, let's just go into some individual conditions. So let's look at Paget's disease. So if you look at this X-ray, you can clearly see the bony architecture on the right hip, and that should really signal alarm bells to say, right, what is going on with this patient? And you should take a full medical history in terms of not just their hip pain, as Nikhil mentioned in the previous talk about how bad their hip arthritis is, how bad their symptoms are. But then you need to take the full medical history in terms of how well controlled their Paget's is, are they on any medications? And then it's very important that you do full leg films of, long leg films of the whole lower limb so you can assess the deformity. And more importantly, if you're in doubt, you should get a CT scanogram from the hip to the ankles. You should get a lateral view as well, because the challenges here are femoral deformity in AP and lateral planes. The bone is quite tough, so it's quite a sclerotic bone, and hence bony resection, reaming and broaching is going to be very difficult and challenging. There's also a higher risk of aseptic loosening. So the tips are, make sure you have long leg films and a CT scanogram if you do not have long leg films available in your hospital. You have to plan deformity correction. So this is your pre-op planning. You have to measure the angles and see whether or not you can get away with a standard stem, or whether you need to do a proximal femoral osteotomy in AP and lateral planes. As I mentioned before, these patients bleed more than normal, so you have to consider cell salvage. There are some studies to show that uncemented implants actually work better in Paget's disease. it's not proven beyond doubt, but certainly I would consider that. And this is what we did in this case. Needed deformity correction and processes. Okay, so let's go into DDH. So obviously this is quite an extreme case, and just to highlight how bad a DDH case can be. So it's clearly a high DDH. So let's go into some classification for DDH first. So one of the common ones is a Crow classification. I'm sure you would have come across this before. And as you can see from Crow 1 to Crow 4, the proximal displacement of the head and the femur keeps increasing, and clearly the femoral head subluxation increases as well. So the case I just showed you before is clearly a Crow 4 with significant proximal displacement and a femoral head that is fully dislocated. What I also find useful actually is this next classification, which actually guides your management. So you could go on from a dysplasia to a low dislocation to a high dislocation. So let's think about this for a minute. So the dysplasia is a subtype A, and that actually is probably the commonest, hopefully you'll see in your practice. And that's because of good management of DDH screening, followed by public harness. So, you know, the management by our pediatric orthopedic colleagues has been great, and hence a lot of the adult hip practice we'll see is the dysplastic hips with some shallowing of the acetabulum. Now, in these cases, hopefully you can get away with your normal processes, cemented or uncemented cup, and hopefully you don't need to worry much about the femur either. The low dislocation cases, B1, are where the false acetabulum still covers more than 50% of the true acetabulum. And these are where you need to reconstruct the roof of the acetabulum, but they are still relatively easy, and you could use the femoral head as an autograft and reconstruct the superior roof of the acetabulum. And then from B2, C1, and C2, these are the really difficult ones where there's significant lack of coverage of the acetabulum, or that it's a very high dislocation where actually there is no acetabulum. So make sure you've done this. So what are the challenges? Now, even when you have the type A or the B1 that I just mentioned before, make sure you have done adequate pre-op planning, because these are the patients who have excessive femoral neck anteversion. So if you've not planned this, what will happen is your stem, which you often put parallel to the neck, would be in excessive anteversion. These are the patients who have valgus neck shaft angle. So therefore, you have to do your leg length discrepancy or leg length equalization measures. You have to use these very, very carefully. There's hypoplastic intramedullary canal. There is rotational mismatch between the metaphysis and the diaphysis. This contracture of the abductors, especially higher the dislocation, the tighter the abductors are. So you may need to do some subperiostal release of the abductors. You have to plan for shallow acetabulum or acetabular deficiency, and how are you going to reconstruct it. And most importantly, there's excessive acetabular anteversion as well, and that has to be part of your pre-op planning. So if you're not careful, native anteversion of the femur is excessive, and there's excessive acetabular anteversion as well. And therefore, if you, in this case, if you line up your acetabulum parallel to the TAL, and if you line up your femoral stem anteversion parallel to the neck, as you would do in a primary total hip in most cases, your combined anteversion could be as much as 50 to 60 degrees, and that has a very high risk of anterior dislocation in these cases. So what are the tips? So this is obviously a talk in itself, but we'll certainly go through some salient principles. So you need to go through rigmarole of 5 steps of pre-op planning. You have to evaluate the pre-op leg length discrepancy and look at all the measures you're going to try and correct that. Second, you need to look at relocating the hip center. So if it's a type B2, C1, or C2, how are you going to bring the center down? Where is a true hip center? What is the difference in the leg lengths, and how are you going to bring it back down to the hip center? You need to predict the use of shortening osteotomy. So you need to think what's the sort of leg length discrepancy and how much we need to shorten the femur. You need to choose your appropriate implants based on your prior planning and whether or not you need modular stems, and you need to achieve primary stability and make sure your combined anteversion is not excessive. So this is what we've done in the case I've just shown you before. The cup, we managed to bring it down, but clearly we needed to do a shortening femoral osteotomy. And this is a case of a low DDH where you could see it's a B1 where the pseudoacetabulum is still more than 50% coverage with the true acetabulum. Here we could use the femoral head autograft to reconstruct the superior acetabulum. We've used that to screw that in. The other options you could have is you can use the metal augments like TIFM augments, TM augments, but generally bear in mind these are younger patients and therefore autograft would be much better to reconstruct their bone stock as compared to going for more metal. Okay, just on similar themes, I'll just show you this case where you'll see a lot of young adults who've had proximal femoral osteotomies, acetabular osteotomies as a kid by the pediatric orthopedic surgeons. And you get a case like that where you've got bilateral proximal femoral deformity. Now, when you get a case like that with the X-ray on the left where you've just got a pelvis X-ray, you need to make sure you've got the full length femur X-rays. You want to make sure you've got AP and lateral views, and ideally you want a long leg film or a CT scanogram. And then what are the challenges? So, well, you need to make sure you can map the deformity, and that's in 3 dimension. You need to get the center of rotation angulation, which is called the CORA. The deformity surgeons, deformity correction surgeons use this on a regular basis. You then need to think, is the deformity bad enough to need a corrective osteotomy, and whether you can get away with a short stem versus a standard stem. Now, in my practice, I've never been really convinced using the mini stems or the mini hip or the short stems, as you call it. Lots of companies make it, but you have to think whether that's something you're happy with. Now, the advantage of that would be that you can get away without a massive corrective osteotomy. And clearly you want to correct or manage the leg-length discrepancy. And this is what we did in this case. We corrected the deformity and we've used, this is an SROM stem, but the advantage of this is when there's a metaphyseal diaphyseal mismatch, you need the modularity in your stem to address both of these issues. I'm just going to go through some trauma cases because they are often the cases where you get secondary arthritis. So let's look at this case. It's a clear subtroch non-union. This X-ray is 11 months down the line following the initial fixation, known case of rheumatoid arthritis, was on lots of disease-modifying drugs. Clearly, there's no callus and it's a biological failure. So the issues here were, well, do you refix or do you think arthroplasty? Clearly, there's poor proximal femoral bone stock. You need to think about the greater and lesser trochanter because they were comminuted. And if you were to replace it, do you use a calcar replacing stem or do you use a proximal femur replacement? Okay, so here it was a biological failure, so refixation was not an option we were considering. And when we went in, we were thinking of calcar replacing stem, but there was too much combination, and really we went for a proximal femur replacement. Let's look at this. Now, it's a similar X-ray in terms of implant failure. It's a failed DHS fixation. Looks like a transverse type subtroch fracture. It's a greater trochanter, partly united, lesser troch has united. Some of the screws have broken. So in your prior planning, you need to think here, right, do I have enough proximal femoral bone stock? And hopefully the answer seems yes, and I don't think we need to be as drastic and think of a proximal femur replacement here. The question is, can you refix that? Personally, I do not feel much merit in refixing. There's a lot of resorption of the femoral neck, and hence a replacement would be the preferred option here. And this is what we went for. So we did a conical stem, which is a calca replacing stem, and we reattached the greater trochanter to it. And another similar example where it's a failed nail, the screws have backed out, the femoral neck is resorbed, or it's not fully healed, certainly. And another one where we did not feel there was enough bone stock within the femoral head to refix that. So if you get cases like this in the exam, think in your FRCS Orth Viva, you need to think your rationale for refixation versus replacement, and that will determine on the bone stock, and is it a mechanical failure or biological failure, and then you can advise your decision. So here again, it was a replacement, as you can see, because there was not enough in the femoral head, and we could reserve the proximal femur. And then a couple of simple or relatively simpler cases where it's AVN secondary to cannulated screw fixation, as you can see here. But the femur, there's no major deformity, neither it's in the acetabulum. So we've managed to get away with a standard cemented total hip replacement. Now, there are some papers of cemented versus uncemented when it's a failed DHS or a failed cannulated screw. There are pros and cons of both options. The difficulties here are when there are screw holes, do you get adequate cementation? Do you get adequate pressurization? And generally the answer is yes, you can do that. You'll need to block the holes while cementing. And equally, this is an example where we used an uncemented stem. Okay, so I'll go on to a couple of more challenging cases now. Takedown of hip arthrodesis. It's not something, thankfully, we see commonly. It used to be a thing of the past where hip arthrodesis was reasonably commonly done a few years ago. So we still see some patients lurking around with this. The difficulty they get is clearly no pain from that hip, but they get pain from the contralateral hip, and they get severe back pain and ipsilateral knee pain. Now, if you were to consider taking down a hip arthrodesis, in exam scenario, you should really say this should be by a dedicated hip surgeon or a revision hip surgeon. But the principles would be that the challenges are going to be significant shortening of the leg. You need to assess the status of abductors, and that generally is through an MRI scan, and you can do nerve conduction studies. You need to assess the quality of your femoral, the bone stock of the femur, the acetabulum. You obviously have to resect into the neck in situ, and then recreate the acetabulum by reaming through it. And more often than not, you'll need to do a shortening osteotomy. And this is what we did in this case. Okay, I'll just leave you pondering on these couple of interesting cases. It's a case of osteopetrosis, marble bone disease with a previous osteotomy. So again, imagine doing a hip for a case like this. It'll be really, really challenging. But and another case where on the left, a hip arthrodesis, so difficult to judge the anatomy here, plus a broken some sort of nail device, and again, it'll be a logistical nightmare. Right, thank you very much.
Thank you, Kuntal. That was quite a complex scenario. I think most of these cases are quite complex. They're probably for exam purposes, but you would always say that you would involve somebody more interested in revision work to take upon these cases rather than jumping on them.
Of course.
For the exam purposes. Thank you, Kuntal. So for our last talk, I would like to invite Mr. Nikhil Pradhan. He's a colleague of mine based at Warrington and Halton Hospital. He has an extensive revision practice, periprosthetic fracture. I'll get it straight to Nikhil to listen to what he has to say. Nikhil, do you want to share your screen with us, please?
Yeah, sure, Prakash. Sharing my screen now. Okay, welcome everyone. Thanks, Prakash, and thanks, Bios, for inviting me for this talk. I'll try and entertain you for 15 minutes with periprosthetic fractures. If you look at the prevalence, then quoted in literature, it varies from about 0.5 to 3.9%. A bit of a technicolor slide, but we are between Halloween and Diwali, so I'll not make any excuses here. But what you can see is the difference between intra-op and post-op. You can see that the risk for a primary cemented hip is 0.1% compared to an uncemented hip, which is 3.9%. So you've got to be careful of your technique when you're doing an uncemented total hip. And when you look at the risk in revisions, it is 14% with an uncemented revision. When we look at the post-op periprosthetic fractures, then the risk is 0.6% in primaries, and it's pretty similar between cemented and uncemented total hip replacements. And these are the figures from the Mayo Clinic, where they've looked at around 24,000 cases of hip and revision hips. So if we then move on to post-operative periprosthetic fractures, and we look at various papers, we find that overall 70 to 94% of type B fractures have a loose stem with osteolysis. And this is looking at the Swedish registry and the Mayo Clinic and some papers. 93% have minor trauma or fall. So this is not something that you see with major trauma. And 7 to 8 years is the routine sort of follow-up time from a primary hip when you see these fractures. Though I must say this trend is changing, and I'll take you through that. There does not seem to be a significant change between males and females, and the BMI does not seem to affect periprosthetic fractures a lot. So why is it important to look at periprosthetic fractures, and what is the impact of periprosthetic fractures on mortality rate? So looking at the Swedish registry, when they looked at revisions for periprosthetic fractures versus revisions for other causes, there's a higher rate of mortality when you're doing revision surgery for periprosthetic fractures. Furthermore, a very good paper in 2007 by Bhattacharya et al. States that the mortality rate is 11% at 1 year for periprosthetic fractures. Now compare that with primary hips, which in the same paper is quoted as 2.9%, and in fracture neck of femurs at 16.5% at 1 year. So you can see that periprosthetic fractures do have a high mortality rate at 1 year. And another interesting finding from the same paper, and I shall go back to this as we go through the slides, is there's a threefold increase in mortality rate in patients who sustained a fracture at the level of the prosthesis, which are talking about type B fractures, that were treated with an open reduction internal fixation versus those treated with revision arthroplasty. The most commonly used classification is the Vancouver classification. There are modifications of this. You have type A, B, and C. Type A has greater trochanter, lesser trochanter. And then again, the subtypes between this will be what is the displacement? Is it less than 1 centimeter or more than 1 centimeter? B1 is with a well-fixed stem. B2 is with a loose stem. And B3 is with poor bone stock. And C is where the fracture is distal to the stem, the implant or the cement implant composite. Apart from the routine investigations, I would say that we need to look at UTI if these patients are most likely elderly patients coming from nursing homes. Remember to look into that. Look for ESR and CRP, or essentially inflammatory markers, to see if there's an infection. Check DVT, as we found that these patients are, again, elderly patients. Have they been immobile for a while? And are you going to think about what happens post-op as well? If it's an unwitnessed fall, especially coming from a nursing home, do your initial check for a head injury. If in doubt, get a CT scan done. Now, in case of how do you investigate the fracture itself, the fracture pattern is extremely important, and I would suggest that all of these patients need a CT scan. I would suggest an MDT, and whether it's a radiology department MDT or a discussion with your colleague to decide this is your plan for this particular periprosthetic fracture, it is useful. And if these patients are elderly, then discussing it with your anesthetist before you actually bring this patient to theaters is not a bad idea. So what patients' variables should we consider? And do they have an impact on how you treat these patients on their outcomes? And most papers now quote that the physiological aid is important when deciding what is the outcome, what was the pre-op mobility status, what are the comorbidities, what bone stock is available, and what is the healing potential of this bone. Have you got osteolysis? Is the stem loose with osteolysis, thin cortices? Is this going to be a difficult one to fix? Is there osteoporosis, which means are you going to get good fixation if you're going to try and fix this fracture? Previous surgeries also make sense. What I would say to you is think fracture neck of femurs. We are very well averse. When we look at fracture neck of femurs, we think about pain relief, stability, early mobilization. I would say translate those principles to periprosthetic fractures and you'll probably head in the right direction. There's been a slight change in trend. In the previous years, periprosthetic fractures came with osteolysis, loosening, and then the fracture. What we are seeing with improved survival of cemented and uncemented stems and increasing life expectancy is an increasing trend of fractures with osteoporotic bones. And hence, it's not very easy to achieve good, stable fixation. Remember, there's always going to be a race when you fix these fractures between failure of your fixation and fracture healing. So let's go through the classification. If you get an intraoperative type A fracture, you should ideally fix it, consider protected weight bearing. If it's postoperative and it's displaced more than 1 centimeter, less than 1 centimeter, protected weight bearing, giving a walking aid will probably allow this to heal. If it's more than 1 centimeter displacement, consider fixation. Unless, of course, you're dealing with a really elderly patient and the patient expectations are low. I shall jump to the type 2B. I'll come to the type B1 as we go further. So type 2B is a loose stem. You've got good proximal bone quality. And the decision here is normally to revise this. Now, when you consider revision, you're going to consider what are the variables here. Is this an elderly frail patient? Am I revising a cemented stem? Now, it might be worthwhile to think, do I need to remove all of that proximal cement? Can I go in there, take the stem out, reduce the fracture, and use a long cemented stem and get away in an elderly frail patient, full weight bearing mobilization, get this patient back on their feet? If it is a young patient with a cemented stem, think about it. Do you need to remove all the cement? If you need to remove the cement, do you need to consider an ETO? You'd rather do an ETO to start with than go after the cement and then find that you've split the femur in a way that's not controlled. Do you need to consider for long cementless stems? So pre-op planning on all this is important. If you are on a type 3, which is a loose stem, but the quality of bone is poor, then really you need to think of distal fixation. So now you're saying, I want to achieve rotational stability, good distal hold, maybe with locking screws, and salvage this patient. So let me now take you back to the B1, which is a well-fixed stem. And what are the treatment options? Now remember that 70 to 94% of patients in type B have a loose stem. So when you see a B1, I would say, think about it, look at your CT scans, make sure you're looking at a B1 and not a B2. Then look at the fracture pattern and the age of the patient. So if you've got a long spiral or an oblique fracture, much better to fix this full weight bearing mobilization. Now, when you say fixation, it's extremely crucial that you plan your fixation well. Where does this fracture end? Is there a way that I can have screws that are in the proximal fragment, which will give me a good hold? I would always consider a double plating, a plate which is lateral and a plate which is anterior. Try and achieve compression at the fracture site. And think about how are you going to position your plates and your screws so as to get good purchase on bone. And if you were just to go blindly into this, you'll find that the risk of failure of refixation is very high. If you get a B1 which is well fixed and the fracture pattern is a short oblique or transverse fracture, the patient is an elderly patient, minor fall, think about, is there osteoporosis? Am I really going to manage to fix this well and get good hold? And if you're in doubt with this, it's not a bad option to say that I'm going to revise this despite a well-fixed stem and get early mobilization on this patient. So if you've got a B1, and this is a case where I say that you've got, again, a short oblique fracture, look at the fracture edges. Is it sclerotic? Are you looking at a stress fracture? Again, think about what is the healing potential of this bone. Am I going to consider going in for a revision? Because remember, again, Bhattacharya in his paper quoted that there's an increased risk of mortality, 3 times increased risk for fixation compared to revision. The type C, a well-fixed stem, distal fracture, you need to fix. You can fix this if you can get a good reduction with a single plate with good compression. Okay, let me take you through some quick examples. So this is a type A. You can see on the X-ray to your left that you've got a small intraoperative trochanteric incomplete fracture, which has been caused when this saw has cut across at the neck. Post-operatively, this patient is mobilized, complains of pain, and the check X-ray shows that the fracture is now complete. This is less than 1 centimeter displaced. You treat it conservatively and it heals and the patient does well. This is the type B1 that I said that you need to be careful and you need to look into what are you dealing with. Because again, this is a B1 because you've got cement which is in the distal fragment, and I consider that as a composite implant where you've got the implant and the cement there. Look at the edges. Are these edges sclerotic? Is this a stress fracture? And think about what is the healing potential of the bone. The endosteal healing, you've got cement there, so all of that needs to come out. Then go to strip all of the periosteum to put a double plate. Are you going to get good fixation? So think about all of this before you fix it. This was fixed, a single plate, lateral side, good distal hold, can't be sure of the proximal hold, and is there good compression at the fracture side? Now, it's difficult to comment on a 2-dimensional X-ray, but you might say that this could have been compressed better. There's always a race between healing of the fracture and the implant, and then you end up with a fracture. And now you've got, again, an elderly patient. You've got a scenario where, is this infected? So you go through all of that, and then eventually you revise this. This was revised to a uncemented, distally locked implant, and the patient did well. But you got to consider all of this before you consider fixation or revision, and your technique of fixation has to be, I think, absolutely crucial. This is an X-ray. Again, you're saying, is this a B1 or a B2 uncemented prosthesis? And one of the, I would say, diagnostic things here is look at where the implant is. It's well within the distal fragment, and you've got displacement of the proximal fragment. This is more likely to be a B2 because you've got displacement of the proximal fragment here. Worthwhile getting a CT scan done, as I said, on all of these patients, and you can see the fracture extends posteriorly all the way up, and this patient needs a revision elderly flared patient who had an uncemented prosthesis, you can get a good reduction, put a cemented stem, and these patients can do well. If it's a young patient with a B2 fracture, so this was a hybrid fixation, cemented stem, uncemented cup. These are the post-op x-rays. This patient did very well. I think it was about 3 years down the line that he came off his push bike and fell, and this was his fracture. So you're looking at what is the fracture pattern here. Again, get a CT scan. How many fragments? Where is the cement? And then what is your plan? Are you going for a cemented or an uncemented revision? Think about how are you going to remove the cement? You've got an ETO that's already done for you. And then you can go in, plan your revision, fix it, and then with protected weight bearing in this patient, you can achieve good healing. This is a B2, an uncemented stem. Again, here, no collar out there. And you can see this has sustained a fracture. This was about 7 years post-op. And this has been fixed. You can see here, it's a distally well-fixed stem. And then the fracture has been wrapped around the stem, and healing has been achieved. A slightly complex C3 fractures, you'll see more and more of these as you go through patients who are rheumatoids. So knee replacement distally, there's a complex fracture in a rheumatoid, and there's a revision surgery on the top. So this was fixed with a single plate using minimal invasive surgery in a way to try and protect the healing potential of the bone, and went on to heal. And you can see there are clips here which are suggestive that this patient was given some sort of exogen treatment. Some people call it voodoo science, but it seems to work in some people's hands. An interesting one, and I think you might start seeing these as you look at the next 5-10 years. Primary hip replacement. This is one of my patients, done in 2011, and this was the X-ray 2020 post surgery. And then the patient came to Mr. Chandran with pain in the thigh, and the X-ray revealed a small nodule sort of thing. And when you take a close-up of that, you can see that there's a stress fracture developing there. Now, these are bisphosphonate fractures, and you've got to be very careful with these. And this will be the new sort of conundrum that orthopedic surgeons will have to deal with in periprosthetic fractures. So a CT scan was done to plan exactly how far away this fracture is from the tip of the prosthesis. Where can you get in screws? Can you get 1 or 2 screws out here? Now, unfortunately, while we were waiting for planning this surgery, the patient has a fall. And the patient then came with this periprosthetic fracture. And you can see there now, sclerotic edges, short fracture. So remember, when you see a fracture, even though it is a complete fracture, think about, is it a stress fracture? Have you got sclerotic edges? Now, this was fixed. And I must say, Mr. Chandran has done a fantastic job. As you can see, he's achieved compression, but he's also achieved to get 2 screws in the proximal fragment, double plating, and hopefully this will go on to heal. This was literally done last month. Okay, to summarize, I would say that 80 to 90% of prostheses are loose in type B fractures. So remember, think about B2, consider revision. When you are in your exams, think about fracture pattern, patient factors, healing potential. Think fracture neck of femur, elderly patients, 1 operation, you want to achieve stability and mobilize full weight bearing. And as I said, watch out for the B1. If you are going for fixation, think about double plating, compression at the fracture site, plan the placement of your screws and plate. If in doubt of healing potential or bone stock, think about revision. And I would stress again in your exams that you're talking about MDT meetings, team approach with an anesthetist, your scrub team, the kit that you have, and medical backup, especially with patients who have multiple comorbidities. Thank you.
Thank you, Nikhil. That was quite extensive. You covered all the scenarios for
So I'm unmute now.
including the complex ones, good for the exam purposes. Now going on, I think I'm very conscious we are slightly overrunning on time. And most of the questions which have been asked by the delegates have been answered, I can see in the chat box. I think there are one or two which probably would benefit from being explained in more detail. First one is to Mr. Nikhil Shah. There is a question on consenting in virtual clinics. You know, does it change practice or do we just carry on as how we do normally? What is your view on that?
Last year, I took part in a clinical negligence conference with some barristers in Leeds in September 2019. And both the QCs that were there, we discussed this quite extensively. And I don't remember the name of the judgment, but I'll try and dig it out for you. But this point has been tested in the court, and the judge accepted that in the modern world, when everything is virtual and it's a perfectly reasonable way of communication, there is no reason at all um, why a virtual communication cannot be allowed, so long as you have actually seen the patient at least once before clinically and examined the patient to make sure that surgery is the right option. I think I will feel very reluctant to see a new patient with primary hip arthritis on Zoom TV and list him directly for a hip replacement.
Okay, thank you. There's one more question for you, Nikhil. This is from, can't remember the name. The question is, you know, when you're doing trauma cases, obviously sometimes the patients are seen in the clinic and consented by some other team, and then the trauma surgeon gets to see the patient on the day. Is there any implications of consenting one stage, two stage, or is the whole patient journey taken as one experience? What is the concern?
See, in an ideal scenario, the consent should be obtained by the surgical team or the person who is going to do the surgery. But in the real life scenario, particularly in an NHS where we all have fixed job plans, fracture clinics on some days, operating on other days, I think it's an ideal that is impossible to achieve. But so long as the person who has seen the patient in the fracture clinic has dealt with the topic adequately, and then you go and see them just before surgery and confirm that the decision making was sound, options have been explained, patient does understand the risks, and then proceed with the trauma operation, I don't see how that should be a problem. In fact, that also happens in elective surgery. Sometimes, you're on annual leave and your fellow lists a patient for surgery. Sometimes the fellow is on annual leave, you list for surgery, but then the fellow does the operation in your absence. So this is very common and I don't think we can avoid it. So we just have to make sure that the process is robust and that we've sort of documented that it is robust.
Thank you. There's a question for Mr. Gudina. There is a question which asks, is there any upper age limit for doing labral repairs, or is it just based on the pathology?
There is no age limit as such, but if you look at the literature, above 40, the hip arthroscopy doesn't give great results because inherently they will have some arthritic changes in the joint. But certainly it all based on the severity of the arthritis. As long as the joint space is well preserved, I'll tell I have recently, one of the patient been referred by my colleague from Liverpool. She's 64, she had a labral repair and I followed her up at 1 year just a couple of weeks ago and she's doing very well. So there is no age limit. It's the disease what she need to look in particular.
Thank you. There is a question for, I think I'll ask Kuntal this question. In total hip replacements for fracture neck of femurs, there is a question, is there any time limit to extend the precautions, or do you think they're more prone for dislocations? What is your view, Kuntal?
I think there are enough studies out there to show that there is a higher risk of dislocation in fracture neck of femurs. One clearly is that they are not used to a stiff hip, and therefore their expectations of moving the hip and their quality of life, and that the compliance with hip precautions is not great. So I always tell my patients that there's a much higher risk of dislocation, and I quote a couple of papers that are commonly used. Precautions, what you can take, well, depends what we all use in our practice, but the choice of approach, the choice of implants, think of dual mobility. A lot of units are using dual mobility. I don't actually use it as a routine practice for my acute neck of femurs. I still use a 28 head or a 32 head, and that still works well in my hands. But think of a dual mobility solution if you want to.
Thank you. And I'll probably ask my last question to Nikhil Pradhan. There is a question which says, why do Vancouver C have a high risk of failure or non-union? Nikhil, do you want to throw some light on that?
Vancouver C do not have a high rate of non-union. It is the type Bs, when you fix them, that they have a higher rate. So the Cs do reasonably well if they're well fixed. I think the important bit here is that if you've got a C which is close to your implant and your fixation is not adequate, so when you fix the proximal fragment that is not well fixed, then you'll end up with failure. So most of the failures that we see in type Cs are probably technical, that you've probably not achieved very good fixation. So I would say, yes, look at healing potential, osteoporotic bones, and how you're going to fix it. But it is failure of fixation. As I said, it's a race between implant failure and fixation.
Great. Yeah. Thank you. Thanks, Nikhil.
Thank you. Prakash, can I just say something?
Yeah, sure. I think I'd like to thank all the presenters. It was really excellent, informative talk. Thank you very much, personally from my side and from all the delegates. Now I'll pass it on to Manish. I think he has some announcements to make.
Thank you. Thank you so much, Prakash. All I was going to say that hats off to you. You have put in an amazing show. Well done. Thank you very much, all the speakers. All the talks were immensely useful to all of us. So thank you giving your precious time on a Sunday. Thank you, Sunil and BJ, for helping in organizing, and these BIOS webinars are going well, and I'm sure we can do more. BJ has already sent out a link for feedback.
You need to copy it to everybody, Manish.
Sorry?
You need to copy it to everybody, or I can copy it.
I'll send it out. Yeah, I'll send it soon. So that link we need, if you don't mind, can you please give us the feedback, and then you can print out the certificate. And last thing is the reminder date for your diary. So next webinar is on foot and ankle trauma. We got a good line of speakers and topics which are useful to all of us: Lisfranc fractures, calcaneal fractures, talus fractures. So see you all on 22nd of November. Thank you very much. Bye-bye.